Welcome back to Nclex Made Easy 91. This channel is all about making nursing concepts simple, clear, and exam-focused. Today, we'll go through key endocrine Nclex practice questions with answers, rationales, and test-taking strategies to help you build confidence and pass your exam. Make sure you watch until the end so you don't miss important tips that could appear on your test. Let's get started. Question 1. A patient is diagnosed with hyperparathyroidism. The nurse will expect to see an elevation in which lab value? A. Serum potassium. B. Serum calcium. C. Serum phosphorus. D. Serum glucose. Answer: B. Serum calcium. Rationale: in hyperparathyroidism, the parathyroid glands secrete excess PTH, which increases calcium release from bones, increases calcium absorption in the intestines, and reduces renal excretion of calcium. This causes hypercalcemia. Phosphorus levels often decrease because PTH promotes phosphate excretion in the urine. Potassium and glucose are not directly affected. Strategy: when you see hyperparathyroidism, immediately think increased calcium, decreased phosphorus. Use the word root. Para equals alongside thyroid, but its main job is calcium balance. Eliminate distractors not related to calcium regulation: potassium, glucose. Question 2. What is the most common cause of hyperparathyroidism? A. Chronic kidney disease. B. An adrenal adenoma. C. A tumor of the pituitary gland. D. A non-cancerous growth, an adenoma, on one of the parathyroid glands. Answer: D. A non-cancerous growth, adenoma, on one of the parathyroid glands. Rationale: primary hyperparathyroidism is most often caused by a benign adenoma on one parathyroid gland. This adenoma increases PTH secretion, leading to hypercalcemia. Chronic kidney disease causes secondary hyperparathyroidism, not primary. Pituitary and adrenal tumors are unrelated. Strategy: remember, primary equals problem in the gland itself. Look for adenoma as a common cause of glandular overactivity. Eliminate options that refer to different organs: pituitary, adrenal. Question 3. A patient with hypoparathyroidism is at risk for which electrolyte imbalance? A. Hypocalcemia. B. Hyperkalemia. C. Hypernatremia. D. Hyperglycemia. Answer: A. Hypocalcemia. Rationale: hypoparathyroidism is a condition of low PTH production. Without PTH, the body cannot adequately mobilize calcium from bones, absorb calcium from the GI tract, or conserve calcium in the kidneys. This results in hypocalcemia, which can cause muscle spasms, tetany, and cardiac arrhythmias. Strategy: link hypo with low. PTH raises calcium, so if PTH is low, calcium will be low. Eliminate unrelated electrolyte changes: sodium, potassium, glucose. Question 4. The nurse assesses a patient and notes a positive Shostak sign. This finding is indicative of which condition? A. Hypercalcemia. B. Hypocalcemia. C. Hyperkalemia. D. Hypoglycemia. Answer: B. Hypocalcemia. Rationale: a positive Shostak sign occurs when tapping the facial nerve triggers twitching of facial muscles, indicating neuromuscular excitability caused by hypocalcemia. Hypercalcemia causes decreased excitability, not twitching. Potassium and glucose imbalances do not cause this sign. Strategy: associate Shostak with calcium, low. Both start with C. Eliminate unrelated choices: glucose, potassium. Question 5. What is the primary medical management for a patient with hypoparathyroidism? A. Increasing fluid intake. B. Administering calcium and vitamin D supplements. C. Surgical removal of the parathyroid glands. D. Administering a high phosphorus diet. Answer: B. Administering calcium and vitamin D supplements. Rationale. The main goal in hypoparathyroidism is correcting hypocalcemia. Calcium supplements replace the lost calcium, while vitamin D enhances calcium absorption from the gut. Surgery, C, would worsen the condition. High phosphorus intake, D, would further lower calcium levels because calcium and phosphorus have an inverse relationship. Strategy. When PTH is low, calcium must be replaced directly. Look for calcium and vitamin D as standard therapy. Rule out answers that make the condition worse. Phosphorus surgery.
Question 6. A patient is diagnosed with a pheochromocytoma. What is the most significant clinical manifestation associated with this condition? A. Profound hypotension. B. Severe intermittent hypertension. C. Chronic constipation. D. Hypoglycemia. Answer B. Severe intermittent hypertension. Rationale. Pheochromocytoma is a tumor of the adrenal medulla that secretes excessive catecholamines, epinephrine and norepinephrine. This leads to paroxysmal, sudden, severe, hypertension, headaches, palpitations, and sweating. Hypotension is incorrect because catecholamines raise BP. Constipation and glucose changes are not hallmark features. Strategy. Remember, pheochromocytoma equals adrenaline surge. Think fight or flight symptoms, high BP, tachycardia, sweating. Eliminate hypotension. Question 7. A patient preparing for surgery to remove a pheochromocytoma, the priority nursing intervention preoperatively is to A. Monitor blood pressure and heart rate frequently. B. Encourage the patient to ambulate to prevent venous stasis. C. Administer oral fluids to prevent dehydration. Or D. Provide a high-fiber diet to prevent constipation. Answer A. Monitor blood pressure and heart rate frequently. Rationale. Preoperative care focuses on stabilizing blood pressure and preventing hypertensive crises since manipulation of the tumor can release large amounts of catecholamines. Monitoring vitals closely helps anticipate dangerous spikes. Other measures, mobility, fluids, diet, are important for general care but not priority. Strategy. Use ABC priority, circulation, BPHR is the greatest concern. Always stabilize the cardiovascular system first. Question 8. A patient with Cushing syndrome is at high risk for which of the following? A. Fluid volume deficit. B. Injury due to brittle bones. C. Hypoglycemia. Or D. Severe hypotension. Answer B. Injury due to brittle bones. Rationale. Excess cortisol increases bone breakdown and decreases calcium absorption, leading to osteoporosis and fractures. Cushing's also causes hyperglycemia, not hypoglycemia. Sodium retention causes fluid excess, not deficit. Hypertension, not hypotension, is typical. Strategy. Think Cushing's equals too much cortisol. Too much cortisol weakens bones, raises glucose, and raises BP. Eliminate options inconsistent with cortisol excess. Question 10. A patient with a history of diabetes mellitus is admitted with a foot ulcer. The nurse understands that this is likely related to which complication of diabetes? A. Hyperglycemia. B. Peripheral neuropathy. C. Diabetic ketoacidosis, DKA. Or D. Hypothyroidism. Answer B. Peripheral neuropathy. Rationale. Peripheral neuropathy causes decreased sensation in the extremities, so patients may not notice small injuries. Poor circulation, peripheral vascular disease, and high glucose levels impair wound healing, making foot ulcers common. Hyperglycemia and DKA are metabolic issues, not the direct cause of ulcers. Hypothyroidism unrelated. Strategy. Always connect foot problems and diabetes equals neuropathy plus poor circulation. Eliminate unrelated endocrine issues. Question 11. What is the primary difference between type 1 and type 2 diabetes? A. Type 1 is treated with oral medications, while type 2 is treated with insulin. B. Type 1 is caused by insulin resistance, while type 2 is caused by a lack of insulin production. C. Type 1 is an autoimmune disease with a total lack of insulin, while type 2 is characterized by insulin resistance and impaired insulin secretion. D. Type 1 is more common in adults, while type 2 is more common in children. Answer: C. Type 1 is an autoimmune disease with a total lack of insulin, while type 2 is characterized by insulin resistance and impaired insulin secretion. Rationale: in type 1 diabetes, autoimmune destruction of pancreatic beta cells causes absolute insulin deficiency. In type 2, tissues become resistant to insulin and the pancreas cannot secrete enough to compensate. Oral agents are used in type 2, but insulin is always required in type 1. Strategy: look for autoimmune equals type 1 and insulin resistance equals type 2. Eliminate answers that oversimplify or mix up the causes. Question 12. A patient is experiencing hypoglycemia. Which of the following is a classic sign or symptom? A. Warm, dry skin. B. Fruity breath odor. C. Tremors, sweating, and confusion. D. Q-small respirations. Answer: C. Tremors, sweating, and confusion. Rationale: hypoglycemia causes activation of the sympathetic nervous system, leading to shakiness, diaphoresis, palpitations, confusion, and anxiety. Warm, dry skin and fruity breath odor suggest hyperglycemia/DKA. Q-small respirations are also a DKA sign. Strategy: remember, cold and clammy needs some candy. Hypoglycemia equals cool, sweaty, confused. Question 13. A patient with newly diagnosed type 1 diabetes is learning to administer insulin. The nurse should emphasize the importance of rotating injection sites to prevent which complication? A. Hypoglycemia. B. Hyperglycemia. C. Lipodystrophy. D. Diabetic ketoacidosis. Answer: C. Lipodystrophy. Rationale: repeated insulin injections in the same site cause lipodystrophy, or thickened or depressed fatty tissue. This interferes with insulin absorption and can make glucose control erratic. Strategy: associate lipo equals fat tissue. Rotating sites prevents tissue changes. Eliminate metabolic complications, hyperglycemia, DKA. Question 14. What is the purpose of a glycosylated hemoglobin A1C test? A. To measure blood glucose levels at a specific moment in time. B. To measure blood glucose levels over the past 2 to 3 months. C. To measure the body's response to an insulin dose. D. To diagnose diabetic ketoacidosis. Answer: B. To measure blood glucose levels over the past 2 to 3 months. Rationale: hemoglobin A1C reflects average blood glucose over 8 to 12 weeks because glucose binds to hemoglobin in RBCs. This is the gold standard for evaluating long-term glucose control. Strategy: keywords long-term or past 2 to 3 months equals A1C. Blood sugar at one moment equals fingerstick. Question 15. A patient with diabetes is experiencing a dawn phenomenon. What is this characterized by? A. An increase in blood glucose levels in the morning due to the release of growth hormone and cortisol. B. A drop in blood glucose levels during the night. C. An increase in blood glucose levels after a meal. D. A severe drop in blood glucose levels after exercise. Answer: A. An increase in blood glucose levels in the morning due to the release of growth hormone and cortisol. Rationale:
The dawn phenomenon occurs due to nighttime release of growth hormone and cortisol, which antagonize insulin and raise morning glucose. Strategy: associate dawn equals sunrise equals morning rising glucose. Eliminate options unrelated to early morning patterns.
Question 16. The nurse is educating a patient about the sick day rules for diabetes management. The nurse should instruct the patient to A. Stop taking insulin or oral anti-diabetic agents. B. Monitor blood glucose levels less frequently. C. Continue taking medication and monitor blood glucose levels more often. Or D. Drink sugary beverages to prevent dehydration. Answer C. Continue taking medication and monitor blood glucose levels more often. Rationale: during illness, stress hormones raise glucose. Patients should never stop insulin, even if not eating. Frequent monitoring is needed to adjust insulin and prevent DKA. Strategy: on the Nclex, sick day always equals keep taking insulin plus monitor closely. Eliminate an answer that says stop meds. Question 17. A patient with type 2 diabetes is taking an oral medication that belongs to the sulfonylurea class. How does this medication work? A. It increases the body's tissue sensitivity to insulin. B. It stimulates the pancreas to secrete more insulin. C. It delays the absorption of carbohydrates in the intestines. Or D. It inhibits the production of glucose by the liver. Answer B. It stimulates the pancreas to secrete more insulin. Rationale: sulfonylureas such as glipizide and glyburide work by stimulating beta cells to release insulin. Biguanides, like metformin, decrease hepatic glucose production and increase insulin sensitivity. 8-carbose slows carb absorption. Strategy: know the major drug classes. Sulfonylureas equals more insulin. Biguanides equals less liver glucose, and alpha-glucosidase inhibitors equal slow carb absorption. Question 19. What is the most common cause of hypothyroidism worldwide? A. Autoimmune disease. B. Iodine deficiency. C. Pituitary tumor. Or D. Surgical removal of the thyroid. Answer B. Iodine deficiency. Rationale: globally, the leading cause of hypothyroidism is iodine deficiency because iodine is essential for thyroid hormone synthesis. In developed countries, autoimmune Hashimoto's thyroiditis is the most common. Strategy: watch for worldwide in the question. Iodine deficiency. If it says in the US, HS equals Hashimoto's. Question 20. A patient is admitted with thyroid storm. What is the priority nursing intervention? A. Providing a warm, quiet environment. B. Administering anti-thyroid medications and beta blockers. C. Encouraging ambulation. Or D. Restricting fluid intake. Answer B. Administering anti-thyroid medications and beta blockers. Rationale: thyroid storm is a life-threatening emergency caused by excess thyroid hormones. Priority management includes anti-thyroid drugs, PTU and methimazole, and beta blockers to control tachycardia and hypertension. Strategy: always pick the answer that directly stabilizes the crisis. Eliminate comfort or non-urgent options. Question 20. What is the function of the anterior pituitary gland? A. To produce melatonin. B. To secrete antidiuretic hormone ADH and oxytocin. C. To produce growth hormone GH, thyroid stimulating hormone TSH, and adrenal corticotropin hormone ACTH. Or D. To regulate calcium levels. Answer C. To produce growth hormone GH, thyroid stimulating hormone TSH, and adrenal corticotropin hormone ACTH. Rationale: the anterior pituitary produces GH, TSH, ACTH, FSH, LH, and prolactin. The posterior pituitary releases ADH and oxytocin. Melatonin is secreted by the pineal gland. Calcium regulation is controlled by parathyroid glands.
Strategy. Break it down. Anterior equals many hormones, GH, TSH, ACTH. Posterior equals ADH plus oxytocin.
Question 21. A patient has a deficiency of ADH. This would likely lead to which condition? A. Diabetes mellitus. B. Diabetes insipidus. C. SIADH. D. Addison's disease. Answer B. Diabetes insipidus. Rationale. ADH deficiency, kidneys excrete large amounts of dilute urine, diabetes insipidus. SIADH is the opposite, too much ADH. Strategy. ADH equals water reabsorption. No ADH equals lots of urine, insipidus. Too much ADH equals water retention, SIADH. Question 22. A patient with SIADH is experiencing which fluid and electrolyte imbalance? A. Hypovolemia and hypernatremia. B. Hypervolemia and hyponatremia. C. Dehydration and hyperkalemia. D. Fluid overload and hypokalemia. Answer B. Hypervolemia and hyponatremia. Rationale. SIADH is excessive ADH, leads to water retention, fluid overload. Dilution lowers serum sodium, hyponatremia. Strategy. Think SIADH equals soaked. Too much water equals dilutional hyponatremia. Question 23. The nurse is preparing to administer desmopressin, DDAVP, to a patient. This medication is used to treat which condition? A. Hyperthyroidism. B. Hypothyroidism. C. Diabetes insipidus. D. Diabetes mellitus. Answer C. Diabetes insipidus. Rationale. DDAVP is a synthetic ADH analog used to treat diabetes insipidus by reducing urine output. Strategy. Link desmo, acts like ADH, only matches DI. Question 24. A patient with newly diagnosed hyperthyroidism asks why they feel anxious and irritable. The nurse's best response is A. Your anxiety is a normal response to being diagnosed with a chronic illness. B. The excess thyroid hormones can increase your metabolism, which can lead to these feelings. C. You are experiencing a form of depression due to the illness. D. This is a side effect of the medication you are taking. Answer B. Rationale. Excess thyroid hormones increase metabolism and nervous system activity, leading to anxiety, irritability, and restlessness. Strategy. Always connect symptoms back to the pathophysiology of the disease when explaining to patients. Question 25. What is the most common cause of Addison's disease? A. Chronic steroid use. B. An autoimmune disorder. C. A tumor of the pituitary gland. D. An infection of the adrenal glands. Answer B. An autoimmune disorder. Rationale. In most cases, Addison's disease is caused by autoimmune destruction of adrenal cortex. Infections like TB can also cause it, but are less common. Strategy. Nclex loves autoimmune as a cause. Unless otherwise specified, it's the safest choice.
Question 26. A patient with Addison's disease may exhibit which of the following clinical signs? A. Weight gain and moon face. B. Hyperglycemia and hypertension. C. Hyperpigmentation of the skin and mucous membranes. D. Edema and fluid retention. Answer C. Hyperpigmentation. Rationale. In Addison's, low cortisol leads to the pituitary releasing more ACTH. ACTH has melanocyte-stimulating hormone activity, causing dark patches in skin and mucous membranes. Strategy. Cushing's equals moon face, weight gain. Addison's equals weight loss, bronze skin. Question 27. A patient with Cushing syndrome is at risk for developing which of the following? A. Hypoglycemia. B. Metabolic acidosis. C. Hypernatremia and hypokalemia. D. Hypovolemia. Answer C. Hypernatremia and hypokalemia. Rationale.
Cortisol excess causes sodium and water retention, hypernatremia, and potassium excretion, hypokalemia. It also raises glucose, not lowers it. Strategy? Remember, Cushing's equals too much cortisol plus too much aldosterone effect. Think sodium up, potassium down. Question 28. What is the primary function of the adrenal medulla? A. To produce androgens and estrogens. B. To secrete cortisol. C. To secrete epinephrine and norepinephrine. D. To regulate sodium and potassium levels. Answer C. To secrete epinephrine and norepinephrine. Rationale: the adrenal medulla releases catecholamines, epinephrine, norepinephrine, for fight or flight response. Cortisol and aldosterone are adrenal cortex hormones. Strategy: medulla equals adrenaline, cortex equals cortisol. Use first letters. M equals medulla equals catecholamines. Question 29. The nurse is teaching a patient with diabetes about the importance of foot care. The nurse should instruct the patient to A. Wear open-toed shoes to allow the feet to air out. B. Soak their feet in hot water to improve circulation. C. Check their feet daily for any cuts, blisters, or sores. D. Use a heating pad on their feet to relieve pain. Answer C. Check their feet daily. Rationale: due to neuropathy and poor circulation, foot injuries can go unnoticed and lead to infection or amputation. Daily inspection is essential. Strategy: best answer is always prevention. Eliminate anything that increases injury risk. Open shoes, hot water, heating pads. Question 30. Which of the following is a classic clinical manifestation of hypothyroidism? A. Weight loss and diarrhea. B. Heat intolerance and epiophthalmos. C. Bradycardia and cold intolerance. D. Nervousness and tremors. Answer C. Bradycardia and cold intolerance. Rationale: hypothyroidism slows metabolism, leading to cold intolerance, fatigue, weight gain, bradycardia, constipation. Hyperthyroidism, Graves' disease, causes epiophthalmos, weight loss, heat intolerance, and tremors. Think hypo equals everything slows down, hyper equals everything speeds up. Thanks for watching Nclex Made Easy 91, where we make nursing simple and success inevitable. If you found this helpful, hit like, subscribe, and turn on notifications so you never miss your next study boost. See you in the next video.